The scope of the Swedish study and the method we used in that study, we wanted to know if there are any clinically meaningful differences in the real-world effectiveness of antipsychotic treatments concerning risk of rehospitalization, risk of treatment failure, or risk of death. So we used a nationwide database which includes all patients in Sweden aged from 16 to 64 years who have been treated with schizophrenia diagnosis. So we had information about the treatment, and then we had also information about the prescriptions that the patients take to the pharmacy to pick up their medication. So we know what kind of treatment they used, and then we have also information about mortality. And by linking all these databases, then we can see what kind of outcomes there are related with specific treatments. Doing observational study has also some advantages compared to randomized controlled trials, because in randomized controlled trials we usually have a very highly selected patient population. So it might be something like 5 to 10% of all patients who are the most cooperative patients without any comorbidities or somatic problems and so on. But in observational studies we can use nationwide database and include everybody. So there is no issue of generalizability of the results because it includes everybody. Mortality has been debated a lot in the treatment of schizophrenia, because some people think that the side effects might actually be the reason for the excess mortality in schizophrenia. If we look at meta-analyses on randomized controlled trials, there are two meta-analyses showing that when the patients are randomized on active antipsychotic arm, they have from 30 to 50% lower risk of death compared to those patients who are randomized on placebo. However, RCTs are usually rather short, something like 8 or 12 weeks. So how can we know what happens in 5 years, 10 years, 20 years span? So then the observational studies are the only way to look at this kind of issue. And there has been several observational studies which have looked mortality and antipsychotic treatment. And to my knowledge, all large observational cohorts show the same result, showing that risk of death is lower when the patients are using antipsychotic compared to time when the patients are not using antipsychotic. So this has been observed in several countries. And also in the Swedish study we observed the same result, seeing that when the patients are using antipsychotics they have a lower risk of death compared to time when they do not use antipsychotic. When we have a new patient and then there is diagnosis of schizophrenia and the patient is treated in the hospital, there is a good response and the patient is discharged to outpatient care, everything goes fine. Then we have the question for how long should we continue antipsychotic treatment. Some treatment guidelines say at least 1 year, some others say maybe up 2 years, some say maybe up to 5 years. But nobody has really known this because there has been no long-term data on this. So therefore we did a study by using a Finnish nationwide database to see, is there a certain time point when the risk would go down, so it would be safe to discontinue antipsychotic medication. So when we looked at these first episode patients, we looked at what is the risk of relapse or risk of treatment failure if the patient stopped medication during the first year of treatment, during the first 2 years of treatments, between 2 to 5 years of treatments, or after 5 years of using medication. So to our surprise, we could not see any safe time point when the risk would go down and it would be safe to stop the medication. It seems to me that at least during the first 8 years of the illness, it is not possible to say that it would be safe to stop antipsychotic treatment. The Swedish study was published in JAMA Psychiatry and the Finnish study was published in American Journal of Psychiatry. So these two journals are one of the most widely read psychiatric journals in the world. When we look at the results from the Swedish study, we can see that there are clinically meaningful differences between specific antipsychotic treatments. We can see that clozapine was associated with low risk of rehospitalization and also long-acting injections of several antipsychotics. So it seems that when we compare long-acting injection of the same medication to the oral form of the same medication, the long-acting injections seem to work much better than the oral ones. When we think about the role of relapse consequences, we should note that when the patients have a first, second, third relapse, every time it seems to be the case that the level of functioning seems to go down. So in that sense, it is very important to try to avoid relapses to maintain level of functioning and quality of life among these patients. When we look specific antipsychotics, we could see rather big differences, so that clozapine and several long-acting injections were associated with the lowest risk of relapse. Implications for clinical practice. Our studies suggest that certain kind of treatments should be used more, especially in certain countries. We observe that clozapine and long-acting injections are working well, much better than many other drugs that have been used previously. In certain countries, the problem is that there is no reward for doctors or nurses decreasing relapses, because in certain countries, the more you have patients coming back to the hospital, the better, because then the hospital gets some money. But if we think about the well-being of the patient, so I think that the treatment guidelines should state that there are certain treatments which are associated with better outcome than some others. So I think that this should be stated more clearly. If we compare the situation in the treatment of schizophrenia, for example, to the situation in the treatment of cancer, so if the oncologist would know that giving the same medication as injection would be associated with about 30% lower risk of relapse of cancer compared to giving the same medication as oral, so I guess that the oncologist would prefer giving the medication as injection. So why does this not happen in psychiatry? When we think about the reasons behind a relatively low proportion of patients on long-acting injections, the usual answer from the medical staff is that they say that the patients are not willing to accept long-acting injections. Well, actually this has been studied. Professor John Kane in US did a study with his colleagues. They wanted to find out what is the percentage of new patients with schizophrenia who prefer long-acting injections over oral treatments. So they prepared a psychoeducational slide set for patients, for families, for doctors and nurses. And now they have analyzed the results, and these have been published in the Journal of Clinical Psychiatry. The results show that about 70% of first episode patients preferred long-acting injections, so only 30% of the patients wanted to have orals. I think that this tells quite clearly that the main bottleneck in wider use of depots is not the attitude of patients, but it is the attitude of the staff. Concerning clinical guidelines, there might be two problems. One problem might be are the guidelines as they should be, and the second problem is, do doctors and nurses obey these guidelines? Actually, it seems to be the case that these guidelines are not that often obeyed, and it is difficult to say what are the reasons behind not doing like the guidelines say, but again, it might be the case that there is no real incentive or system which would actually guide the staff to do the right thing. This kind of thing has been tried to do in one hospital in Finland. In that hospital, the staff gets extra bonus of salary each year if there is surplus in the budget. but there is a condition, and the condition is that a certain amount of schizophrenia treatment guidelines must be fulfilled. And if these conditions are fulfilled, so then the staff can get the bonus. Obeying the guidelines was observed in this hospital. It could be clearly seen that when this new system of bonus came, so then obeying of guidelines increased quite well. So I guess that this kind of system might actually work. In my opinion, our research and some other research also suggests that guidelines might be modified. Currently, in most of the guidelines, there's text saying that there are certain special situations when you should consider using long-acting injections. Well, in my opinion, the right wording should be there are certain special situations when you should consider using oral medications. Otherwise, it's long-acting injections. Concerning combining psychopharmacological treatments and psychosocial treatments, I think that antipsychotic treatment makes it possible to use efficiently psychosocial treatments like CBT, and other way around, psychoeducation benefits use of psychopharmacological treatments, leading to better adherence and compliance. So both of them make the other one work better. When we look at data in Nordic countries, we can see that the average age of first episode schizophrenia, or the age when the patient receives the first diagnosis of schizophrenia, is above 30 years. And actually in Finland we observed that vast majority of all patients who got their first diagnosis of schizophrenia had been prescribed already antipsychotics for a long time. So it seems that there has been disorder for many, many years before, and there has been a lack of something like even up to 10 years before reaching the right diagnosis. And this is quite strange to me, because I think that this right diagnosis should be done more rapidly. And I don't know what is the reason behind this. If we again have analog situation, for example, in dermatology, and there would be a black spot on the skin, and dermatologist would know that it is melanoma. So I think that he wouldn't say that it's no worry, it's just a mole, but the dermatologist would try to treat that thing as efficiently as possible. And I think that in treatment of schizophrenia we have this problem that we don't treat the patients in the early phase as efficiently as we could. If we sum up the results of the Swedish studies, we can state that antipsychotic treatments are associated with substantially lower mortality. So it seems to be the case that it is the lack of antipsychotic treatment which is associated with excess mortality in schizophrenia. And if we think about the relapse, we can see rather big differences between specific drugs. So clozapine and long-acting injections are associated with the lowest risk of relapse. If we sum up the results of Finnish first episode study, it tells that we cannot see any safe time point to discontinue antipsychotic medication during the first 8 years of illness.